Hi, good morning, everyone, and welcome to the Stanford Medicine Alliance for Disability, Inclusion, and Equity's first ever Disability and Telehealth Conference. I'm Peter Poulos. I am a clinical professor of radiology at Stanford University, and I am founder and co-chair of SMADI. I'm a middle-aged white man with brown hair and blue eyes wearing a white shirt. And I believe my co-pilot is here, Dr. Srinivasan. Would you like to join us?
Oh, indeed. Thank you. I'm Malathi Srinivasan. I'm a clinical professor also at Stanford University, and I'm co-director of the Disability and Telehealth Conference. I am a South Asian woman with black curly hair, brown eyes, and today I'm wearing a uh, dress and pink jacket with a really big gold necklace. So for many people with disabilities, telehealth has really become a public good. And we want to build a case for you today that you should begin to care about this. We have over 1,000 people here from over 50 countries. So I know that there's a large interest in this topic. And we're so excited today to share with you some of the latest research that can show us how we can deliver high quality telehealth care for all.
I'd like to
Dr.
de We'd love to dedicate this conference to our late friend and colleague, Andres Gallegos. I had the privilege of meeting him several times and learning from him. He actually gave our keynote and had planned on joining us here today, but unfortunately, he passed in December, and we'll miss him greatly.
So we wanted to give you a bit of a tour of what's going to happen throughout the day. I know this is a long day. We're going to go from 8 a.m. Pacific to 4 p.m. Pacific. And for all our friends and colleagues joining us from all around the world, I know this is a long day, but we have built in some breaks. So after these initial opening remarks, we're going to have a couple keynotes by the National Council on Disability and the American Telemedicine Association, who's partnered with us to put on this conference, and a welcome from the Association of American Medical Colleges, the AAMC. We'll then focus on specific communities within the disability community, focusing on issues with telehealth and hearing, then a telehealth and vision, issues with mobility. We have, after lunch, a phenomenal panel on technology and really bold solutions to be able to improve telehealth for all from a technology standpoint and from a health system standpoint. We'll then close out with a session on autism and IDD, as well as on geriatrics and cognitive disability, and the provider's approach thinking about telehealth when it comes to taking care of persons with disability. And we'll be hearing both from providers who are providing care to persons with disabilities via telehealth, as well as people who have or who are providers who have disabilities themselves.
As usual, we'll be providing CME free of charge. We'll be providing information throughout the conference today. This is a QR code you can scan. Don't rush to do it right now if you don't have to. So we'll be providing it again throughout the day.
Yeah, and we're also going to be putting a survey link into the chat for those people who are interested in getting CME credit. And we will be doing this probably 3-4 times throughout the day. So CME has asked us to take attendance. So if you're planning on doing this, please fill out the form. So one of the things that we wanted to do was share with you the story of this conference, why it came to be, and why you should really care about the intersection of telehealth and disabilities. So we're going to transition to session 1. And we wanted to share with you, this is a very sophisticated audience, I know, and you already probably know that in the United States, about 27%, 1 in 4 people has a disability, and at least one disability. Many people have multiple. And for people who have disabilities, they're medically very vulnerable, and they have both health risks due to their disability, but also a population-based risk like increase in obesity or smoking or diabetes. And as you can see here, and I know many of you are familiar with the CDC infographic, so if you are, please bear with us, that 1 in 4 persons with disabilities a usual healthcare provider. 1 in 4 also have an unmet healthcare need just because of cost within the past year, and 1 in 5 didn't have a routine checkup in the past year. So to solve this, we of course need a very coordinated approach from building inclusive health programs, which is what we're going to be talking about later today, as well as doing research and reducing health disparities.
With disabilities. Some disabilities are acquired later in life, either as a result of an accident, as in my case, or an illness. Some disabilities are progressive, while others are more static. And of course, disabilities can wax and wane, or even sometimes resolve. Disability is diverse. So I had a cervical spinal cord injury on January 5th, 2003. I was initially paralyzed from the neck down, and fortunately, I regained the ability to walk and use my arms somewhat, but my recovery was incomplete. And having been in a procedural subspecialty, gastroenterology, I decided that in order to practice more independently, I needed to change specialties. And so I decided to do 5 more years of training and become a radiologist. And in 2009, I joined the faculty, focusing on pretty much everything but disability. I was just trying to get my life and career back on track. But I founded the Stanford Medicine Alliance for Disability Inclusion and Equity in 2018, and I've been concentrating on that ever since. So then 2020 happened, and as COVID spread, those of us with disabilities were filled with dread. My respiratory muscles, as you can hear, are weak, as is my cough. What would happen to me if I caught COVID? What would happen to my friends? Fear and, in some cases, panic set in as the deaths mounted worldwide. And these are the images we saw. This is from April 2020, a group home in Bayville, New York for people with disabilities. And the article reads that 37 of the 46 residents had tested positive for coronavirus. And so for those of us who see ourselves or a loved one in these images, this was scary. Remember, there was a shortage of ventilators and PPE and no vaccine. And at this time, our hospitals and clinics were shutting down.
So this happened in the setting of a massive increase in telehealth availability. So you may not know, telehealth actually started in the 1960s in America with NASA, and it hadn't really gained popularity or until the 2000s. And by the time 2020 came, telehealth was very available. Up to 80% of hospital systems had it, but it wasn't used very much, about 5%, and the training for healthcare providers was extremely limited. When I joined Stanford in 2018, I came in as a medical educator and a health services researcher doing vulnerable population health disparities research, and I was very interested in technology. And we began to do teaching around telehealth for providers. So there was this perfect intersection between the pandemic, the really vulnerable disability population, and telehealth that we knew needed to be studied and understood so that we could really provide high quality healthcare for all.
And so this convert things brought Dr. Srinivasan and I together. We didn't know each other before this, but we both wanted to focus on health equity research around COVID. And so we created the COVID Journey Project with Stanford funding from Ethics Society and Technology Hub, as well as Seraph and Chem H gave us generous grants. And we did this to explore the healthcare experiences of Americans through the pandemic. We asked, how did the sudden shift to virtual health during the pandemic affect 5 disability communities that we are highlighting today? We partnered with disability organizations across America.
And we began a qualitative scoping study using photo voice or sensory voice. And I know this sounds very technical, but we interviewed people, giving them questions in advance. And we asked them to take photos. And all of these photos are things that they sent us that's shared with permission. And we used these photos as the beginning of a discussion. Their experiences were like, both with in-person care and contrasting that with virtual care. So we interviewed 32 persons with disabilities from around the country, from 8 states in the United States and most regions. And you can see the breakdown of people that we interviewed. It was pretty much a 50-50 in terms of male and female. And we coded all of the interviews and began to ask ourselves, what are we really learning and what are people telling us? One of the first lessons that we learned is that telehealth dramatically increased access to care for almost all persons with disabilities, but there were a lot of things left to do. So this is a woman who shared with us what her in-person experience was like, where was everyone was wearing masks. She couldn't live through the masks, and if people had, or if she gave people masks that had see she could at least see a little bit about what they were doing. So, having that idea of being able to read lips through the screen was helpful. And the as machine language translation and AI translation improved, there were some translations from Zoom and from other platforms that were helpful, but it was still only about 80% accurate. And people needed to use ASL translators. One of our participants here had shared that he actually preferred to have 2 translators, one a hearing translator who could sign into American Standard Sign Language, but then someone else who would interpret the nuance of what the provider was sharing, the physician or their physical therapist or their other providers that they were working with, because there was a lot of nuance within conversation that he wasn't getting just from that translation. For people with low vision or who were blind, they were having difficulty keeping themselves within frame. And some of the technologies that they were using weren't compatible with virtual health. And so they would often revert to phone, for instance.
In the mobility disabilities category, our participants shared that virtual health was really useful because it was accessible and time efficient, limited COVID exposure, and simplified follow-up appointments.
Mhm. But at the same time, they shared that because sometimes their disability wasn't visible through the screen, they would have difficulty communicating the severity of what they were experiencing, and people would overestimate what they could actually do. For persons who were people who would use cues when they were in person with their doctor and could recognize, say, this doctor this physician has a white coat, or could begin to interact, were having more difficulty engaging, and many people were having difficulty using even the simplified technology that was available with different points and clicks. For children with autism and persons with autism, depending on the person, they found the telehealth reassuring in terms of being able to connect because it was a very one-on-one interaction. But the micro cues that they would use in person weren't available. And people who were restless, the children would have a very hard time staying within the frame. And people felt they needed a much wider frame to be able to care for them.
So what we learned is that medicine had definitely become a public good for people with disabilities, but we needed higher quality care. We need improvements to infrastructure, better understanding of our needs, and better training of patients and providers and health systems to deliver better care. So we definitely knew that this conference needed to happen, and we need to move forward the disability and telehealth conversation.
So when we decided to put the conference gratified, we began to reach out through the community, and everyone that we spoke to really answered the calls. I'm going to get very choked up because it was just remarkable. The American Telemedicine Association immediately partnered with us. The National Council on Disability generously not only agreed to give us one of our keynotes today, but also invited us to present our summary findings to them sometime after our white paper is finished. Has begun focusing on this topic already and was really pleased to participate. And we've had so many people from the technology community, Amwell, Zoom, Apple, other groups, all of our researchers, everybody we reached out to not only said yes enthusiastically, but they really felt as if this was taking care of the 27% of Americans important for them. And so we know it's important for you because you've shown up here today.
And now we're going to go to our first keynote. Our first keynote speaker is Ann Summers McIntosh, the Executive Director of the National Council on Disability. The NCD is the advisory council to Congress on all matters related to disability and disability legislation. Ann Summers McIntosh joined the NCD in 2008 as a legislative affairs specialist and served as Director of Legislative Affairs and Outreach for 10 years before becoming ED in 2021. Prior to NCD, she was policy counsel at the American Association of People with Disabilities, a copywriter for Anthem Blue Cross Blue Shield, and a journalist for the Richmond Times-Dispatch. She chaired Not Yet Dead from 2015 to 2019, having joined its board in 2013. Ann attended Virginia Tech on a full merit scholarship, graduating summa cum laude with a BS in business and a minor in communications. At Virginia Tech, she was chair of the Judicial Committee and Opinion Section editor for the Collegiate Times. She's an alum of the Maggie L. Walker Governor's School for Government and International Studies. She earned her JD from William & Mary School of Law, a Chappell Fellow, and was recognized as a Benjamin Rush Health Law Scholar in 2005. She was also a founding member of Students for Equality in Legal Education. So without further ado, Ann Summers McIntosh.
Thank you so much, Peter. It's a real pleasure to be here with you today. I am Ann Summers McIntosh. I'm a Caucasian middle-aged female with shoulder-length, dirty blonde hair, eyes, and plastic brown and clear glasses. And today I'm wearing a dark teal blouse and a navy blue blazer with a lapel pin from NCD. I'm here today in my capacity as the Executive Director of the National Council on Disability, but also as a woman with a congenital musculoskeletal disability, about 30 inches of major joint reconstruction scars and rehabilitation stints under my belt, as well as a family prevalent autoimmune disease that makes me a high utilization consumer of healthcare in America, and most recently afforded me some rather, I'll call them, insightful experiences with well-meaning healthcare providers during some high-risk pregnancies that I had with my 2 preschoolers. It is such an honor to be here today, though my participation is bittersweet. I am the poor substitute for our late chairman, Andres Gallegos, who was due to give this keynote here today, but who passed away suddenly, as mentioned, in December. And my presentation today, as is this whole conference, is dedicated to his memory and honor. The National Council on Disability is, in fact, a federal agency. A lot of folks in the community part of the federal government. We're an independent federal agency, and our mission is unique in government. We don't have the ability to tell anybody, to enforce anybody to do anything, but we have the authority and the mission to tell people what to do. So we advise the president, Congress, and other federal agencies on all matters, cradle to grave, all severities of disability and all disabilities, and all topics of disability. that affect people with disabilities, we advise policymakers on what to do regarding things that affect people's lives. We're comprised of 9 presidential and congressional appointees, an executive director, myself, and professional staff of 11 people. We most commonly provide our advice through fulsome research endeavors that culminate in major findings and recommendations. And I'll be touching on those in just a moment. We touch on all subjects, as I mentioned, but we have been rather prolific in health equity over the last few decades, and in particular, the last few years. So here are just a few of the titles of our research recently that you may be interested in checking out outside of this conference. We've done work in oral health care twice, and how to incentivize dental care providers to treat people with intellectual and developmental disabilities. We've done work in guardianship that obviously touches on decision-making in healthcare environments, organ discrimination, the dangers of assisted suicide for people with disabilities, genetic testing, and we're in fact getting ready to release on June 5th another report on fetal surgery and germline editing. Quality adjusted life years and their impact on people with disabilities, medical futility and disability bias, enforceable, accessible diagnostic and medical equipment standards, how to strengthen the home and community-based service system, which goes hand in glove with healthcare conversations, the impact of COVID-19 on people with disabilities, which Peter touched on. And this all got started around 2009 when we did a fulsome study. It was about a 400-page tome about the current health status of people with disabilities. And that's where we really started documenting the disparities. Now, on the first day of President Biden's administration and on his inauguration day, he designated Gallegos as the chairman of NCD. And approximately 2 weeks later, so he wasted absolutely no time, Andres released his priority and vision statement to the community. And he announced, during my tenure, it's going to be all health equity all the time. And it really was. Happily, our current chair, Claudia Gordon, has announced her intention to retain that focus and priority during her own tenure. Andres and I made many health equity presentations together over the past few years. And so I also want to remark briefly, slides today were a gift to me from Andreas, in large part. He and I were actually iteratively developing a PowerPoint for another speaking event, which we were to be co-presenters at just before he got sick last year. And he had sent me his latest updates to it, awaiting mine. And so I decided to use those slides today to outline my remarks over the next few minutes with you. So in using the slides he last worked on and through the video I'm about to show, which introduces all of you to Andres, for those who may not have had the distinct pleasure of knowing him in life, I determined today to have the distinct pleasure of working with him yet again. And I like to think that I'm actually co-presenting with him today. So without further ado, Andreas, thank you again for continuing to have my back with these slides.
I was honored to be designated as chairman of the National Council on Disability. I am a Hispanic male with fair complexion, exceedingly gray hair, black frame glasses, and I am a proud member of the disability community, class of 1996, having sustained a spinal cord injury resulting in quadriplegia in an automobile accident. As a person with a spinal cord injury, I, like so many others, have experienced the realities of trying to attain medical care while confronting the seismic barriers that still exist despite the over 30 years since the Americans with Disabilities Act became law. So many of us have stories to tell. Sir, you wrote the Americans with Disabilities Act. That's a big friggin' deal. Gentlemen, the National Council on Disability, with 9 presidentially and congressionally appointed members, carries the statutory mission to advise the President, his administration, Congress, and federal agencies on all policy matters impacting people with disabilities. The health and well-being of people with disabilities have long been ignored in this country. This occurs despite the existence of an overwhelming body of studies and reports that unequivocally document the significant and continuing prevalence of health disparities that exist between people with disabilities and our non-disabled counterparts. The National Council on Disability was fighting for federal legislation to protect the rights of persons with disabilities since its inception. NCD has worked to develop a health equity framework to provide policymakers in Congress and in the administration with a blueprint to take action. The adoption of enforceable medical diagnostic equipment standards is just one step towards health equity for persons with mobility disabilities, and is just one component of NCD's pursuit of health equity for all people with disabilities. For an all-of-government approach to address health disparities. The framework was 1 year in the making, with the input of our then council members, members of the disability community, and a dream team of 14 advisors comprised of healthcare disparities researchers, physicians caring for people with disabilities, healthcare and disability law professors, among others. It's a matter of attaining and maintaining good health. It's critically important for everyone, but more so for persons with disabilities. It's truly the predicate to our ability to live, our ability to learn, and our ability to work and earn. Into the forefront of discussions that are taking place in medical schools and perhaps at the associations here. I have to part with you, our house is on fire. The issues that we're talking about here, when individuals like me can't get weighed at medical appointments because there's no wheelchair accessible weight scales, when we don't get transferred onto examination tables for full physical examination because of the inability or the unwillingness of providers to do so, and then we see a heightened percentage of people with spinal cord injuries and mobility disabilities being diagnosed with colon cancer because they're simply not being checked, or prostate cancer because they're simply not being checked. We don't have time for polite conversations in your respective schools. We need some action, and that has to happen. And so I impart to you that our house is on fire, and these issues need to be reduced. Let us remember that disability is a natural part of the human condition. Let us remember that disability is not a characteristic that stands alone, but is one that intersects with all other aspects of a person's identity, such as age, race, ethnicity, income level, sexual orientation, gender identity, and religion. Let us recommit to shaping a future in which all members of this beautiful community can have and enjoy full rights, free from discrimination, to live self-directed, independent lives, to achieve our full potential. Achieving our full potential is only possible if we're able to attain and maintain good health.
So I'll get my own part of the presentation started here with Andreas's own words. Our house is on fire. That is what Andreas said to an esteemed panel of the most senior leaders from the AAMC, the AMA, the ACGME, the Joint Commission, and the LCME, who had gathered at a meeting held by NCD in Washington, D.C. last July, which largely focused on the need for clinical care competency training standards for disability. The fire, of course, is the well-documented health disparities that people with disabilities are gallingly experiencing that demand multi-pronged action to redress. If you're a person with a physical, intellectual, or developmental disability in America today, your life expectancy is less than that of someone without disabilities. You're at a much higher risk for early onset of cardiovascular disease than those without disabilities. You're more than 20 to be obese than those without disabilities. You're more than 3 times likely to have diabetes than those without disabilities. And you are significantly more likely to have unmet dental, medical, and prescription needs than those without disabilities. And if you're a woman with a disability, you're likely to receive much poorer maternity care and less likely to have received a pap smear test or a mammogram than those without disabilities. And if you're an adult who is deaf or hard of hearing, you're 3 times more likely to report fair or poor health compared to those without hearing impairments. And it's because of those well-researched health disparities, which we heard overwhelming amounts of firsthand accounts of, not to mention Andreas's own war stories as a person with a mobility disability, that Andreas set to have NCD create a framework to address those disparities, a blueprint really for how to end them. And it was an all-government approach, and it's available on our website for anyone who would like to take a look. As Andreas said in the video, we relied on an interdisciplinary group that we like to call the Dream Team, and I'm actually hoping that some of them are watching today. So we could not have gotten to the framework finish line without all of them. They were invaluable in helping us, particularly not only determine the kitchen sink of all that needed to be redressed, but also if we could only get a few things done initially, what would set the dominoes into motion? And those became our 5 pillars of the framework. Those 5 pillars are first, special medically underserved population designation, which for those unfamiliar would provide federal funding for health centers, access to loan repayment and training programs, and incentives for physicians to treat the designated group due to higher reimbursement rates and preference to research at federal agencies that studies the medically underserved population. Health disparities population designation. That, of course, happily in September of 2023. So we're very, very grateful for that. That helps coordinate the research, establish centers for excellence for the research, education, and training, and also facilitate those loan forgiveness pieces with NIH contracts with those who pursue research into that population's health disparities. The third one was comprehensive disability clinical care curricula. We know, obviously, physicians often lack the knowledge, experience, and to distinguish clinical concerns arising from disability from those related to other health conditions. A term that all of you are familiar with, likely, diagnostic overshadowing. We've done quite a bit of work in that area as well. And the curriculum piece, too, is important to address that implicit and explicit bias piece that was particularly on display during COVID, as Peter mentioned. For those who are unfamiliar, there were crisis standards of care in a number of states during COVID that were facially discriminating against people with disabilities. Alabama, Arizona, Kansas, Pennsylvania, Tennessee, Utah, and Washington. In those states, they expressly based triage decisions on normative quality of life judgments, or they excluded from treatment outright patients who required any assistance in activities of daily living, or those with certain conditions like moderate to severe intellectual disabilities or moderate to severe dementia. And we believe that is also needed to be clear with all within the allied health professions. Accessible medical diagnostic equipment. Just 2 weeks ago, if you weren't tuned in, HHS OCR finalized a rule updating the Section 504 regulations, which do adopt the U.S. Access Board's standards for accessible medical diagnostic equipment and make them enforceable for the first time. So this was one of the things that Andreas felt absolutely strongest about, and I know it would have been an incredibly happy day for him to have seen that happen. That was just 2 weeks ago that took place. And finally, our 5th pillar was improved data capturing. And that's beginning to happen. We're starting to see some efforts along those lines. Now, the health disparities of people with disabilities are not new at all, and yet COVID really did help put a spotlight on them and unmask them in many ways. And for those unfamiliar, I just want to briefly touch on this, the story of Michael. This was a profound moment for the disability community, so I wanted to make sure you know his name after today. In June 2020, NPR and other news outlets started to cover a story about an audio recording that had emerged and been given to the media between a physician and a spouse of a severely disabled man, Michael Hickson, who lived in a hospital in Austin, Texas, who had been denied treatment for a urinary tract infection, sepsis, pneumonia, and suspected COVID-19. His physician explicitly stated a preference to treat patients who could walk and talk. All life-sustaining treatment, including artificial nutrition and hydration, were withdrawn, and 6 days later, Mr. Hickson died. What many people don't know is that Andreas, in his day job as a disability rights litigator, was actually the widow's attorney in the wake of the story breaking. What alarmed the disability community the most was that here we were in the height of the pandemic, and yet all those decisions I just outlined were made in the normal course of business. Medical rationing and crisis standards of care were not even in effect at this hospital because the hospital was not being overwhelmed by COVID at the time that these things occurred. So this would have been any day in America, never mind the pandemic. The fact that he had suspected COVID seemed a convenient rationalization. So yes, our house is on fire. On display in the case of Michael Hickson was explicit bias. However, implicit bias is a rankling exacerbator as well that must be acknowledged and addressed head on. Many of you are likely familiar with the 2021 Health Affairs piece by Dr. Lisa Iazzoni and her peers that surveyed 714 practicing US physicians. That study found that 82.4% of those physicians reported that people with significant disabilities had a worse quality of life than non-disabled people. Only 40.7% of the surveyed were very confident about their ability to provide the same quality of care to patients with disabilities. Just a little over half of the physicians strongly agreed that they welcomed patients with a disability into their practices. And 18.1% strongly agreed that the healthcare system often treats patients with disabilities unfairly. Now, I'm running out of time here, and I don't believe that there is one silver bullet in addressing some problems, but as outlined in our framework, it will take an all hands on deck approach with buy-in from all quarters, and not only the policymakers and regulators, but from within the medical community and the allied health professions as well. So as I close out my time with you this morning, my charge to you this weekend, as you explore the challenges and solutions aimed at improving the quality and accessibility of telehealth for people with disabilities, is that you never forget what's on the line for people with disabilities in healthcare settings. For people with disabilities who are already struggling to live, learn, and earn on equal footing with their non-disabled peers, people with disabilities make up 12% of the working age population, and yet they account for more than half of those living in poverty. For people with disabilities, gaining and maintaining good health is the for cracking into the equality of opportunity in education, employment, and community life. And poor quality of opportunity in education and employment and community life is they're two sides of the same coin. Without that health piece in place, it's really hard to make progress in the other areas of life. Poor quality or inaccessible healthcare is not just an inconvenience, it's a box out for all equal footing in other areas of life for people with disabilities. Remember Andreas's words, disability is a natural part of the human experience, and it should in no way affect a person's ability to experience excellent, equitable healthcare. It also happens to be, as Peter mentioned, the one protected class that anyone can join in an instant. So accessible, quality, barrier-free healthcare is always universally good for everyone. So thank you for having me today. I wish you a very successful, very engaging, practice-altering conference ahead. Thank you and all the best.
Grateful for your remarks today, your presence, and your support of this important topic. We're really thrilled to hopefully partner with you as we move our white paper forward, and hopefully we'll have some good suggestions from the panelists as well as from the research community and our community that can inform further work in telehealth. So the work that you're doing is amazing, and we can't thank you enough. So we'd like to also now welcome Kyle Zebley, who is a Senior Vice President for Public Policy at the American Telemedicine Association and Executive Director of ATA Action. He leads efforts to advance telehealth, removing barriers for patients, providers, and patients, and he published ATA Action to advocate for policies that enhance access to telehealth services. And previously, he was a chief of staff in the Office of Global Affairs at the U.S. Department of Health and Human Services. And he collaborated with senior leadership on global health policy issues, like drug pricing, health security. He's a real recognized policy expert. He's contributed to organizations including the Federation of State Medical Boards, the World Health Organization, and he recently he also co-authored a paper in Harvard Business Review on telehealth's role in U.S. healthcare. He's unable to join us live because he is traveling right now. I think he's in flight. So he has recorded a few words to give us the lay of the land and what's happening in telehealth in America.
Ladies and gentlemen, I am honored to speak today at the Stanford Disability and Telehealth Conference, co-sponsored by the Stanford Medicine Alliance for Disability Inclusion and Equity and the American Telemedicine Association. This gathering is not only a testament to our shared commitment to accessibility in healthcare, but Gallegos, whose work tirelessly championed the rights of individuals with disabilities. As the Senior Vice President of Public Policy at the ATA, I am privileged to represent an organization that is singularly focused on advancing telehealth. Our mission is clear: to ensure that everyone has access to safe, affordable, and appropriate care, enabling our system to do more good for more people. We stand at the forefront of integrating virtual care into every delivery model, representing a diverse network that spans healthcare systems, academic institutions, technology providers, and payers. Today, I want to address the critical intersection of telehealth and disability, a topic of profound importance. Nearly 1 in 4 Americans lives with a disability, making this a significant segment of our population, one that stands to benefit immensely from telehealth technologies. The advantages of telehealth for the disability community are numerous. Let's talk about how telehealth truly makes a difference for the disability community. Think about the challenges of mobility and transportation. For many, getting to a doctor's office isn't just a quick drive away. It involves coordinating wheelchair accessible transport or arranging paratransit, often days in advance. Telehealth wipes away these hurdles, bringing healthcare to wherever the patient is. Then there's the incredible boost to independence it offers. For those whose conditions make leaving home difficult, telehealth empowers them to manage their health on their own terms. It's about having control over your care in your own space, which can be both comforting and empowering. Health safety is another critical benefit. Telehealth reduces the risk of exposure to illnesses, which is especially crucial for anyone with a weakened immune system. Instead of sitting in crowded waiting rooms, care comes to you safely and securely and appropriately. And let's not overlook the economic impact. Telehealth can significantly cut down healthcare costs, a vital consideration given that individuals with disabilities often face lower median earnings. It's not just about saving money, it's about making healthcare more accessible and affordable for everyone. Yet as we champion these benefits, we must also turn a critical eye to the policies that shape this landscape. The ATA and our companion organization, ATA Action, are vigorously advocating for permanent changes in national and state policy, many changes that were brought about temporarily during the COVID-19 pandemic. These issues include remote prescribing of controlled substances, acute hospital care at home, and more inclusive telehealth Medicare coverage for all Americans, including those with disabilities. As we navigate a landmark year in federal telehealth policy, it's becoming clearer and clearer that 2024 is the telehealth Super Bowl, with critical legislative and regulatory deadlines approaching on December 31st of this year. Here's a strategic look at our key federal priorities and the significant roles Congress, the Drug Enforcement Administration, and the Centers for Medicare and Medicaid Services play in this scenario of the telehealth Super Bowl. The role of Congress in shaping telehealth's future cannot be overstated. The extension of the 2022 omnibus legislation, which has enhanced Medicare by increasing access, the number of providers eligible to provide telehealth, and services across diverse patient populations is vital. Looking forward, we are advocating in Congress for everywhere access. We believe that patients should be able to receive telehealth care no matter where they are, particularly at home. Whether you're in a high rise in New York or a farmhouse in Nebraska, quality healthcare should be just a click away. Next, we want a wider practitioner reach. It's about inclusivity in healthcare providers. We're advocating to include more diverse telehealth practitioners like occupational therapists and speech-language pathologists. This isn't just about expanding services. It's about enriching them, providing a broader range of care to those who need it most. Then there's strengthened rural healthcare. We're committed to empowering federally qualified health centers and rural health clinics to extend their telehealth services. For many rural communities, these centers are lifelines, and enhancing their services can mean the difference between healthcare access and healthcare deserts. Lastly, we focus on enhanced mental health and hospice care. We're working to ease and repeal in-person requirements and continuing to support telehealth recertification for hospice care. It's about providing compassionate, accessible care to those in their most vulnerable times. Now let's talk about the Drug Enforcement Administration. The DEA has a pivotal role in revolutionizing how telehealth prescribes controlled substances. This year, they've extended the in-person waiver until the end of 2024, which over the last 4 years has been a game changer for telehealth providers. Looking forward, the establishment of a special registration process and the elimination permanently crucial. These steps will significantly expand access to necessary medications, ensuring that telehealth services continues to serve as a viable option for patient access care across various regions. Now, let's talk about the CMS pandemic era policies. CMS has introduced significant pro-telehealth regulatory changes that we hope will extend beyond this year. These include clinician privacy protections and other measures that facilitate easier access to telehealth services. These pivotal areas of focus reflect the ATA's commitment to not just navigating, but also shaping the landscape of telehealth policy. Through concerted efforts with Congress, the DEA, and CMS, we aim to secure permanent legislative and regulatory changes that will safeguard the continuation and expansion of telehealth services across the country. Our continued advocacy efforts are crucial as we approach these deadlines. With your support, with your participation, we can ensure that these favorable telehealth policies do not remain temporary benefits, but instead become permanent fixtures in our healthcare system, again allowing us to achieve our ATA mission of doing more good for more people. While federal telehealth policy and the telehealth super our collective mission to expand access to telehealth and virtual care, it's essential to understand the significant role state policy plays in shaping the effectiveness and accessibility of these services. At the ATA, we recognize that states are not just laboratories of democracy. They are also testing grounds for innovations in healthcare delivery. State policies profoundly influence the implementation and efficacy of telehealth services, impacting everyone, especially the disabled community. Our advocacy work is aimed at ensuring that telehealth not only reaches all corners of our nation, but does so in a way that respects and enhances the rights of those with disabilities. Through our model telehealth policy documents, specifically the ATA standardized telehealth terminology and policy language for states on medical practices and on coverage and reimbursement, we provide a blueprint for state lawmakers. These documents provide a healthcare system where individuals have access to care where and when they need it, facilitated by technology that respects and upholds the dignity of every patient, particularly those with disabilities. Our policies advocate for ensuring telehealth services are covered under private insurance and Medicaid to the same extent as in-person services. This is crucial for making healthcare accessible to individuals with disabilities who may face significant challenges in accessing traditional healthcare settings. We emphasize through these documents that the standards of care for telehealth should not differ from in-person care. A practitioner using telehealth must adhere to the same professional standards, ensuring that patients receive quality care irrespective of the medium through which it is delivered. Our policy facilitates the creation of valid practitioner-patient relationships through telehealth, removing the need for any initial in-person visit. This is particularly important for patients with disabilities for whom frequent travel to a healthcare provider can be difficult, expensive, in some cases, even close to impossible. We support the ability of healthcare providers to prescribe medications, including controlled substances, based on a telehealth consultation, as long as it complies with state and federal laws. This capability is vital for continuous and comprehensive care. By advocating for these policies at the state level, the ATA seeks to remove barriers to telehealth that, again, disproportionately affect the disabled. Our aim is to ensure that telehealth is not just an alternative, but a fully integrated option within our healthcare system, offering individuals with disabilities the independence and quality of care they deserve. Our efforts are not just about legislative and regulatory wins. They are about ensuring that telehealth is accessible and functional for everyone, and that disability is never an afterthought in policy development. This conference and gatherings like it are vital for identifying potential accessibility challenges and working collaboratively to create universal access to telehealth. In closing, I urge each of you, providers, technologists, policymakers, and advocates, to join us in this cause. Your involvement can shape an inclusive future where telehealth not only reaches all, but serves all effectively. Thank you for your commitment to this vital work, and I look forward to the discussions and collaborations that will emerge from this conference. Thank you so much, and have a wonderful day.
Really, thank you to Kyle for taking the time and effort to be able to craft remarks on this important topic and sharing really the focus of the American Telemedicine Association as they've been trying for high quality telehealth for all. I think along with the other leadership within ATA, they recognize the need to really focus on the 25 to 27% of Americans who have a significant disability that's affecting their day-to-day life. So we're very pleased and very grateful to Kyle and his team for helping us.
So the Association of American Medical College is a not-for-profit association dedicated to transforming health through medical education, healthcare, research, and community collaborations. We're so delighted to have Katie Reggett, MPH, Senior Program Specialist in Clinical Innovations at the AAMC. She previously worked at UChicago Medicine at the University of Minnesota. She earned her MPH from DePaul University, where she was honored as a notable alumnus in December 2022. At the AAMC, Katie leads initiatives in digital health equity, telehealth, digital health strategy, clinical innovations, and healthcare delivery science. She also co-leads the Digital Health and AI Collaborative with Manit Health. Her recent publications include Digital Health Equity, Current Practices and Approaches of Academic Medical Centers, and Resources and Recommendations for School-Based Telehealth Implementation, both available at the AAMC store. Sure, please, Katie, take it away.
Thank you very much, and hello, everyone. Once again, my name is Katie Reggett. I am joining you today. I'm a woman in her early 30s with brown hair, round glasses, and a black shirt. Going to take a second to share my screen. Give me a very warm introduction, but just to reiterate, I'm a senior program specialist at the AAMC, which stands for the Association of American Medical Colleges. My job and responsibilities include working under one of the 10 AAMC action plans, specifically Action Plan 7, which is focused on improving access to care for all. In the last year, the AAMC has grown and expanded its focus under this action plan to include access to telehealth for patients with disabilities. The AAMC also has additional resources related to broader access for patients, providers, and medical learners with disabilities as well. I'm honored today. I'm going to go through some quick currently available resources that the AAMC has curated, not only from our organization, but other organizations as well. And first and foremost, I want to talk specifically about resources we've curated for telehealth access. The first resource I linked here today was a co-developed the Northern Carolina Division of Services for Deaf and Hard of Hearing. This document is a collection of resources and recommendations for comprehending what accessible telehealth looks like and how to implement that at your institution. The second resource listed is 2 webinars hosted by the AAMC in December 2024, focused on this topic as well. Available for these sessions. Please consider viewing them to learn more about the policy landscape, hear stories about the patient experience, and learn best practices for improving telehealth. Moving into some broader resources, the AAMC has a vibrant community through our virtual community page focused on disability inclusion. I encourage you all to check it out and participate in the ongoing discussion, as well as join it to get input on regular AAMC events around this topic. There is a fantastic resource that under our structural resources that I want to highlight. This includes the AAM resource, Reimagining Technical Standards for Inclusive Medical Education. Another workshop recording you can take a look at, as well as Aligning Technical Standards for 21st Medical Education, which specifically addresses how to make technical resources available for patients with disabilities. I'm going to jump ahead really quickly here and talk about the resources available under the medical education curriculum. The first 2 there are really fantastic services, but I want to highlight the one from the Hastings Center specifically because actually the title of this is Anti-Medical Education, Meeting the Challenges. I want to highlight this for you today because it includes Dr. Peter Pullo's conference co-chair as an author and a great resources for educating the future providers for proper service and understanding for patients with disabilities. Last but certainly not least, the AAMC is committed to this work. I'm committed to this work and are interested in collaborating with you. I've listed the screen today. Please take a second to reach out if you're interested in collaborating or disseminating any of your existing work across our AAMC networks, which expands leaders, learners, providers, all in the medical care all throughout the medical care spectrum, and learning about our growing investment in telehealth and all forms of healthcare in making visits accessible for patients with disabilities. Thank you very much.